Good afternoon, Dwayne. Appreciate the opportunity to address your team. I'm Keith Thompson. I'm accompanied by Jose Garcia, who's our Chief Technical Officer and is kind of the principal architect of the technology that I'm going to share with you today. My background is I'm an ophthalmologist. I was on the Emory faculty for 15 years. Then I was in private practice for 10 years. Then I had a midlife crisis, and instead of getting a sports car or a new wife, I decided to found a telehealth company, which I did with Jose. So it turned out to be much more expensive than the alternatives. But I'm very pleased that we're now in commercial service thanks to our wonderful partnership with the Oakhurst Medical Center and Jeff Taylor and his medical team led by Dr. Uzzle. So many of you probably are familiar with the OMC's first-class facility out on Memorial Drive in Stone Mountain, 25,000 square foot facility. Our telehealth clinic fits in 3 standard size exam rooms in that clinic. And through this telehealth platform, we're able to deliver full service comprehensive eye care to OMC's patients. And I want to share with you just a little bit about our first 6 months of experience working with our partners at OMC. So this is the technology. So once we had the crazy idea to do it, we got into the Georgia Tech Venture Lab Incubator Program, had some access to some really great engineering talent at Georgia Tech that Jose assembled. And this is Jose and our team there out at Georgia Tech. We built our prototype telehealth system, which you see here. I'm not going to spend time talking about the technical aspects, but it's a very sophisticated platform that allows vision testing to be done, comprehensive eye exams, so you get a prescription for your nearsightedness, farsightedness, astigmatism. And it's also linked up with some diagnostic equipment, some very sophisticated technology for early detection of glaucoma, diabetes, and other sight-threatening eye diseases. When it's all fully up and running, this is the telehealth workstation where the ophthalmologist sits. This doctor could be anywhere. He could be in the same clinic. He could be in a clinic across town. He could be in a location in a different state or even around the world. So it works by all it needs really is a high-speed internet connection, and the doctor can sit there. He has access to all the images that you see on your left and a live two-way teleconsultation with the patient in the exam chair in the FQHC clinic. So as I mentioned, when we teamed with Jeff, he found some space in OMC's dental and specialty area that we basically leased from OMC, and we deployed our equipment into those 3 exam rooms. So we have a room for diagnostics where we take eye information, both images and data from the eyes. We have a telehealth room where the actual doctor consultation occurs, and then we have a 3rd room we use for a small optical so we can make affordable eyewear available to OMC's patients. This is a little bigger view of the 3-room setup we have with our diagnostic equipment, telehealth platform, and compact optical dispensary. So those of you in the FQHC world, you're on the front line of taking care of primary care patients, many of whom have a high incidence of sight-threatening eye diseases. And so when we first started working with OMC, we worked with Jeff and Clayton Knox, their CFO, to look at an assessment of their patient base, about 22,000 patients, over 47,000 annual patient encounters. And based on the demographics, we kind of knew going in that there would be a high prevalence of a number of sight-threatening eye diseases such as diabetes, cataracts, glaucoma are the most common. Other sight-threatening eye diseases in your patients include optic nerve diseases, strabismus and amblyopia in children, and various medication toxicities such as plaquenil, methotrexate, and some other drugs. So I want to share with you just a few charts from our first experience. So this is a chart that begins in January of last year, January of 2017, and this is through the first quarter of this year. We opened our clinic the first week in November at OMC, and you can see the orange bars there are the number of ophthalmology referrals from OMC's primary care physicians. So the ambient level before we came along was right around maybe 80 patients per month, and you can see that once we started, the number of referrals stepped way up. And that's really just a function of, being Johnny on the spot, being, hey, there's an eye clinic here now, so I've got an issue with the eye. Let's send you over there and get your eye exam. This is another very important chart for those of you that are interested in HEDIS scores and compliance with preventative care, such as getting diabetics eye exams and whatnot. The blue bar here is the number of closed eye referrals that OMC physicians designate closed in their Athena EMR. And you can see that before we came along, the number of patients that were told to get an eye exam, that were referred for a consultation, that actually got it done and got it documented in the record was about somewhere around 5 to 7 per month. So that the latest data we have now at OMC is that number is up to 38 per month. So by a factor of 5, we've increased the number of referrals that are actually complied with. They got their eye exams, they got it done, and they got it documented in the record. This is the most important chart that I'll show you today, and it has some take-home messages worth remembering. This is the incidence of eye diseases and conditions that we have found in a consecutive series of patients examined in the digital vision clinic at OMC. So if we take this pie chart roughly in half, on the right hand of the pie chart, the blue area, these are eyes that basically they were healthy eyes, normal eyes. The only thing wrong with them is they may have had nearsightedness, farsightedness, astigmatism, and need eyeglasses. Nothing sight-threatening there. Everything on the left side, almost half, are various types of sight-threatening conditions. The three most common, as we expected, were diabetes, cataract, glaucoma. Then there's a smorgasbord of other types of things, such as amblyopia, interstitial keratitis, and various things, less sight-threatening, but are serious conditions that must be reconciled with. The take-home from this chart is if you add up the sight-threatening conditions of diabetes, cataract, glaucoma, retinal vascular disease, amblyopia, about 1 out of every 3 patients in OMC has a sight-threatening condition. So we were kind of astounded by that. We knew that the incidence of pathology would be high, but we were surprised to find it as high as it was. So in our 6 months of working with Jeff and his colleagues at OMC, we're kind of giving ourselves a little scorecard on how we're doing. Dr. Uzzle wanted us to focus first on the diabetics, and that we did, and we've gotten great compliance from the OMC physicians who we partner with. Dr. Teresa Jacobs is here. She sends lots of her patients over, as do her colleagues. And I think we're doing a pretty good job of getting the diabetic patients evaluated, getting comprehensive eye exams, and figuring out who's got retinopathy and needs treatment. The cataract patients are really not much of a problem because these patients tend to self-refer. What happens is the cataract gets worse in your eye, you start losing vision. And at some point, you say, hey, I can't see anymore, and you go to the eye doctor or your caretaker or family member takes you in. The thing we're really having the problem with is glaucoma. And I want to spend a few minutes talking about glaucoma. And I told Dr. Uzzle a week or two ago that we really need to sit down with the OMC team and work out a better way, a more aggressive way to detect these patients. And I wanted to mention a couple patients to illustrate how bad of a disease glaucoma is. So first of all, what is glaucoma? Glaucoma is a condition, or really a series of conditions that affects the optic nerve in the eye, this structure in the back of the eye. The optic nerve collects all the nerves from the photoreceptors in the eye and carries that information to the brain. This is a healthy optic nerve. It's a little hard to see in this light condition, but there's a ring of what we call neuroretinal tissue here. And in glaucoma, that nerve tissue gets damaged, and you end up with this big, large cup, which is basically an empty, hollow shell of where the healthy neural tissue was. The worst thing about a glaucoma is it's terribly insidious. It causes a painless loss of vision over years to decades. It progresses so slowly that patients are unaware that they've lost vision until they get to late in the stage of the disease. They've lost almost all of their peripheral vision. And then in end-stage glaucoma, the patients lose all of their sight and they go completely blind. The bad thing about glaucoma also is that once the vision is lost and the nerve tissue dies, there's no treatment available to restore eyesight. So treating glaucoma is a defensive game. It's about early detection. With new technology I'm going to mention, we can detect it early. And it's about lowering the intraocular pressure to a safe level that preserves eyesight. Now, glaucoma has an extremely high prevalence in African American patients. In middle-aged patients, African American patients are 15 times more likely to have vision loss and blindness than in Caucasian races. And here's a really scary chart. If you look at older African American men, The incidence of glaucoma at age 75 is greater than 10%, 1 in 10. So as folks live longer, this is a disease they become more and more susceptible to. The possible risk factors are listed here. Some of these are controversial because some studies show positive risks, some are not correlated, but clearly African American heritage, a positive family history, and some vascular disease, diabetes, hypertension, and obesity are all thought to raise one's risk for developing glaucoma. I want to mention 3 of OMC's patients just to illustrate to you how important it is to detect glaucoma early in its patients. This patient was referred by one of OMC's physicians. He was 51 years old. He had elevated intraocular pressure and moderate field loss in the left eye, as you see, and very severe field loss with really just a tunnel of field left in the right eye. This gentleman was severe enough we had to send him to Grady to have surgery on his left eye to preserve vision. Here's another patient from Jamaica, 62 years old. He came in with his daughters because he didn't see well enough to get around independently. Glaucoma had taken all of the sight in his left eye, completely blind, no light perception whatsoever. His right eye, he had an extremely small tunnel of vision, and again, required assistance for just everyday living. He also went to Grady to have his right eye operated on to preserve what eyesight he had left. So here actually is a happy case, and this happens to be a patient of Teresa Jacobs. We had lunch today. I mentioned this patient to her. He is a 21-year-old African-American male college student. He came in and told us about a very strong positive family history of glaucoma. He had pressures in the upper 20s, and we were able, with the technology I'm going to show you in a minute, diagnose him with glaucoma at a very early stage in the disease process. Now, if you have glaucoma at 21, you have bad glaucoma. Had we not detected glaucoma in this patient, he would probably be stone cold blind by 35 years of age. That's how bad this disease is when it presents young. So the good news is we now have technology in our digital vision clinic that detects glaucoma at a very early stage in the disease. Back when I was in my training, we didn't have this technology, so we would actually have to wait until this optic nerve structure became severely damaged that you could actually see it with your ophthalmoscope, or they lost visual field before you could diagnose and manage it. Those days are over, fortunately. We have this technology called ocular coherence tomography, or OCT. Think of it as giving us a cross-section of the retina. Think of this as a sonar scan or sonography scan of the retina using light waves. It measures the thickness of the retina. Glaucoma causes the retina to thin as the disease progresses. So we can measure the thickness of the retina with OCT, compare it to a normative database of patients, and you can compare normalized retinal thickness up here to Dr. Jacobs' patient here, and you can see his retina started to thin. This is pathognomonic for glaucoma. We start them on drops, we reduce their pressure, we repeat this scan following the OCT and visual fields, hopefully to stop the disease progression. If we fail to stop the progression, we get more aggressive. We can do some laser treatment to reduce the pressure. Failing that, they go to surgery and basically have a hole put in the eye for an alternate outflow tract to lower pressure. That almost always works. So I tell that story that we want more patients like patient 3 and fewer patients like patients 1 or 2. We want to detect these folks early. So I want to mention a final thing about our program with our digital vision clinic, and that's our partnership with Grady. All this technology is great, but if you have a patient with advanced disease and they need somewhere to go for surgery or tertiary care, where do you go? So we worked with Grady once we got our telehealth system working. They were very excited about it, and they also wanted to establish a relationship with us. So we have entered into a formal business agreement, partnership with Grady. Under that agreement, we refer patients to the Grady Eye Clinic who need surgery or tertiary care. Grady wants one of our telehealth systems, so we're going to install it, one in the Grady Eye Clinic and some primary care satellites later this year. And ultimately where this is going, and I think it's of interest to those of you in the FQHC community, we will eventually be able to teleport subspecialty expertise from Grady Eye Clinic into digital vision clinics on the FQHC campus. So, for example, if your patients have glaucoma in a more advanced stage that need some subspecialty care, then the Grady doctors will be able to be a telehealth consult on those patients. So we're excited about this program with Grady. This is just a list of some OMC patients that we have referred to Grady since we've been there. I think there's 34 patients on this chart. I think it's now up to about almost 50. We're seeing a 7% incidence of patients we see in our clinic end up down to Grady for surgery. Everything in orange is a sight-threatening condition. So you see there's lots of cataracts here. There's glaucoma, there's macular edema, optic atrophy. These are serious eye conditions that need advanced care. The final thing we offer with digital vision is affordable eyeglasses through our digital vision optical. We have eyeglasses for men, women, children, very affordably priced, but we also have the usual kinds of lens upgrades such as photochromic, tinted lenses, and the like. We sent our optician out to mystery shop at both Walmart and America's Best, the value kind of places where your patients would get eye care, and we're equal or below their cost. So we've put together a very low-cost supply chain and can provide very affordable eyewear to your patients. Going forward, we're going to add virtual try-on to the optical, so that'll even increase you won't have to have a huge inventory of frames for your patients, so we'll be able to get basically any kind of eyeglasses they want. And then just some final words about initiatives on what we're doing next with our digital vision clinic program. I mentioned our relationship with Grady. We're going to open a very similar clinic on the Grady campus in a few months on the 3rd floor of the hospital because they want the same capability that we have at OMC down at Grady. The next thing we're going to do is we're talking to Jeff and his team about expanding some medical specialty services onto our telehealth platform. Many of you know OMC has a very large women's health practice, and one of the things that another technology that is amenable to telehealth offering is mammography, and particularly 3D mammography. For those of you that have followed that field, 3D mammography now, or also known as digital breast tomography or 3D mammo, offers patients a 41% greater detection rate for early stage breast cancer. Again, finding the cancer at an early point where treatment tends to be very effective. We're actually partnering with GE Healthcare, who's putting together a very affordable package of technology we hope to make available to Jeff and his team at OMC. And then the final thing that we're doing, and for anybody in this room that's interested, we're in the process of raising some funding, which we hope will be completed by 2nd quarter. That's going to enable us to open telehealth clinics in both Grady satellites and in other FQHCs in the state that are interested in adding this technology to your offering. The benefits are obviously you can offer your patients one-stop medical specialty care, detect and treat sight-threatening eye diseases, which I hope I've convinced you that there's a lot of prevalence of that in this population, and expand that to mammography and other specialty services, which helps all of you with your HEDIS and STAR metrics, as well as getting additional reimbursement from healthcare payers. So thank you all for your attention. I'll be happy to answer any brief questions. Right. Absolutely. Yeah. We certainly think that there are FQHCs throughout the state that could benefit from this technology, and we're open to talking with any of them. We need some. Yes, ma'am. We need a couple to 3, depending on what level of how many services you want. The minimum is 1 exam room for an eye clinic. Our present configuration at Jeff's place, we have an eye clinic and 2 exam rooms. Our next generation of technology will shrink that down to 1 room. I have to pay him less rent too. So, but yes, that's right. We need a standard size. Jeff, I think your rooms are 10 by 10. And we don't need, obviously we need that, and we need a fast internet connection. So So if anybody's interested, I'm gonna leave some of my cards with Dwayne, and I'll be happy to chat with any of you guys. And also, if you're out in Stone Mountain anytime, you're very welcome to come out and see our clinic. We're pretty much there. As you see, I've been working today while he's been at this conference. So we're there Monday through Friday. Good question. Reimbursement done. So we accept all of the payers, or we're trying to get credentialed on all the payers of OMC. So we take the insurance, and then we have mirrored OMC's sliding fee scale. So we sat down with Clayton Knox, and Clayton explained to us how they do their fee scale, how they derive their fee, and we did exactly the same thing. So that's how we would work. And it's actually, I think, worked very well. We do all the billing. Yeah, we pay them a lot. The rent's too high. We're gonna talk about that. But yes. So. Yeah. So we've had. Yes, ma'am. That's a great question. We first didn't think that it would fit. And obviously, both we and OMC would like to avoid lots of renovation costs, right? There's been a big change in the technology in mammography. It's gotten smaller, and you don't need don't lose those. It's gotten smaller, and you don't have to shield the space with lead, okay? So both GE and Hologic came out on site visit, and we can put a 3D digital tomography system in an existing exam room. Well, how rules rule? Well, I mean, obviously, that's a great question. So we're happy to work with anybody where our service adds value. There is a numbers game element to this, right? We have to have a certain volume. Unfortunately, with our partnership with OMC, we kind of know what that volume is to make this sense, to make it work. You know, we need to see about 20 patients a day in our clinic. So at least at this stage, you know, as our model evolves and we can do more and more things via telehealth. So, for example, if we did more services, we would need to see, you know, fewer eye patients because now you're going to see some mammography, you're going to see some ENT, et cetera. Great. Great. I think it would. I think the availability, it depends on, you know, how many annual patient encounters you have in your facility. Yes, this is absolutely state-of-the-art for both diabetes and glaucoma. We thought the diabetics would be the biggest problem. We were wrong. It's the glaucoma. It's so bad. It's a bad disease. Yes, ma'am. We take anybody and everybody, uninsured patients. We take on I think our experience mirrors that of OMC about 30%, Jeff. Does that sound right? Are uninsured. And so we do the same testing that they do, you know, and we put them on the, what is it, Jose, a 3-tiered scale? Yeah. Right. Yes, ma'am. So that's a great question. So right now we don't offer any assistance other than trying to get the glasses as inexpensive as possible. One of the things we're going to do with Grady is we're going to operate a clinic for Grady where we can get glasses for under $25. And we're going to do that while partnering with some online people. Now the selection will be less, right? And they'll maybe look like G.I. Joe Army issue 101s, but they'll be $25 and they can go to school and see. And then there will be some opportunity. I mean, Prevent Blindness, there's a very number of charity organizations that could donate to that so that we would have some funds available that people had absolutely no means, you know, we could get them glasses for $25. So that's in the pipeline too. Yes, ma'am. We're a nonprofit. We haven't made any money yet. But we are organized as a Georgia Limited Liability Corporation. So we're not a nonprofit. Yes. When you say screening device, do you mean the OCT? Okay, there's a variety of screening things. Like, so to do a screening exam to determine if a kid needs glasses, those are very portable. This technology is not portable. It's mounted. It's extremely sensitive. It has to be calibrated. Yeah, basically everybody that goes through our clinic gets a complete eye exam. If they're diabetic or they're a glaucoma suspect, they get a couple of additional things. Yeah, we do comprehensive eye exams. Right. Yeah. Right. Okay, any other questions? I told Dwayne I'd be brief, so thanks very much.